So if you're not familiar, we are part of Kaleidoscope Health and Care. So we're a not-for-profit social enterprise with a mission to work with others to create a future which is kind, connected and joyful. And we work across number of health and care organisations, providing consultancy services to bring people together and help people develop change that works. We do that in a number of ways. So we do lots of engagement, really proud to have led on the staff engagement for the development of the 10-year plan. We support people in developing effective collaborations, organisational development, supporting service design and change, strategy development and insights and impact. And research and evaluation. So do always feel free to get in touch if you would like us to support you. So in today's session, we are going to share a bit about what we've heard from staff during the 10-year plan, engagement about the conditions for successful implementation, and the potential barriers that could derail it. We're going to have an opportunity to hear from our panel of experts on their experience around approaching large-scale change and how what lessons they've learned on how it works, and hopefully give you some practical and actionable ideas on where to start your organisational journey. We're focusing very firmly on implementation today, so we're not going to get into the detail of what's in the plan. I feel like that would dominate the whole session. So we're not going to get into the detail of the plan. We're also not here to debate whether we think it's the right or wrong plan. It's here. We've now got clarity on what's being proposed, and now the work begins to implement it. And we all know that making change happen and successfully stick is the really tough part. So we want to focus today on what we can learn from the evidence and past history of change, and consider how we can apply this to this implementation of this plan, so we can all play our part in delivering an NHS fit for the future. At Kaleidoscope, we really want to focus on, moving from implementation of this plan as another mandated activity to implementation as purposeful and impactful change that actually works. So we're going to be running through till 2 o'clock to do that. Just before we move on, in our continual focus on working to support teams, we've got a couple of further offerings that are coming up. So we'll be doing an in-person workshop in September in London, venue TBC. But you can register. I think Ariadne is going to pop in the chat. You can register for that on the link. It's going to be on the 11th of September. We've also got copies of the little Kaleidoscope guide to implementing the 10-year health plan, which if you want a copy, do drop Ariadne an email on the message that her email address is going to be put in chat with your preferred postal address, and we will send you a copy of that. So do get in touch with Ariadne if you would like to come to the event and or would like a copy of the guide. If you've just joined, I can see more people have joined since we kicked off. We're going to be using Menti today, so you can scan this QR code, or you can go to menti.com and enter the code 61677201. If you want to do that and give me a thumbs up, that would be fantastic. It should be in chat as well, so if there are any problems, you can log back in there. Before we move on to our panel, and just as a test of Menti, do you want to let us know where are you joining from us today? Hopefully it's in the British Isles, otherwise you'll have to put it in the sea somewhere, and pop in chat if you are lucky enough to be somewhere else. But do let us know. Fantastic. So we've got some good representation from across England. Wow, someone's in looks like they're in Land's End, so that's amazing. Fab. Great to see so many of you joining from all parts of England. No Ireland, Scotland, or Wales as yet, but fantastic. Really, as I said, appreciate people joining on such a hot and sunny day. Hopefully you'll get a chance to get out into the hot weather at some point today. So thank you for joining us and sharing where you are. Lots of us in London, but fantastic for sharing where you're joining us today. So I'm going to stop speaking in a moment. You'll be happy to hear. And we're going to hear from colleagues who are joining us today on our panel. So we've got Naomi Fulop, who's Professor of Healthcare Organisation and Management at University College London. William Roberts, who's Chief Exec of the Royal Society for Public Health. And our very own Shane Carmichael, who's part of Kaleidoscope, who's also at UCL today and has it even in his background. So thank you so much to all panelists for joining us. Really appreciate it. So just before we move on, so we're really proud to have led on the staff engagement aspect of Change NHS, which fed into the development of the 10-year plan. So we engaged directly more than nearly 4,000 staff overall through a series of online events, small focus group conversations and face-to-face deliberative events, and captured a diverse sample of health and care staff with representation across all of the regions, different sectors, different roles, different pay bands, and feel proud to have engaged actually a lot of people who don't generally get engaged in these sort of processes. So speaking to porters, to healthcare assistants, getting a really wide range of different perspectives to feed into the development of the plan. And feedback was really positive, and people felt that their input was genuinely heard and valued. A lot of what we focused on is, being open and honest that actually, these shifts are not new or novel. And actually a lot of the challenge, even though progress has absolutely been made over the last few decades in each of these areas, change is hard. So we focused a lot of our conversations on why people felt change was so hard and how could we make change work in today's challenging context. So that was really, we're really proud to have done that as part of this process. I'm going to hand over now to Shane to kick us off, focusing on what we know about change that works and actually what we heard from staff in a bit more detail about what they need to make this change work. Shane, over to you.
Brilliant. Thanks, Claire. Hi, everybody. Thanks for being with us today. I'm Shane, part of the team at Kaleidoscope. As Claire said, I'm also have the privilege of teaching at UCL a day a week. I've just literally finished a session on leading change with a bunch of lovely clinicians. Most of them haven't read the 10-year plan yet, but we did have a good conversation about which AI agent was able to produce the best summary. I just mentioned that because it is interesting how much of our time people like us might be taken up thinking about this. Might be a slightly different reality for people who are working on the ground. I should say I'm also the chair of a community mental health care provider, so I have a very personal professional interest in this too. So two parts to my very cheap warm-up act for our main speakers. One is just a little bit to say about what we know works, and then more importantly, what did NHS staff tell us about what they need to make this change work. So this slide is a social defense against our anxiety. It's a little bit of an introduction to, we've been working in this space for a very long time, right across health and care. And out of that, we have built, I think, a pretty sophisticated understanding of change and the characteristics of good change. And specifically, we've been doing a lot of work over the last couple of years in the three pillars, the three shifts that are laid out in the 10-year plan. And if you want to know any more about those things, about what worked, what we learned, and what didn't, you just give us a shout, or you can check that out on the website. So you can hopefully take a little bit of credibility from what we're going to share. Claire, can you pop on to the next slide?
Absolutely.
So this is a summation of what you might imagine as a very large data set. So it is necessarily a little bit of a simplification. But at all of the events that we ran, we asked staff a number of questions. And the two main questions were, what barriers and risks exist to making this change work? And then what approaches are needed to mitigate those risks and enable change that works? So very essentially, this was NHS staff telling us this is what might get in the way. And if we can do this, our chances of success will go up. Now, a couple of caveats around this. These are presented as very generic pots, but of course, within each of these, there are a whole host of individual ideas, hypotheses, suggestions, which have different ranges of complexity. But they broadly describe the mood of staff going into this. Now, many of these will be familiar to those of us who have been around for a long time. I'm not going to drain these slides, but I am leaving them here so you can have a chance to think about them. We are going to bring them back up and get a sense from you on what you think are most important. But I'm just going to pick out a couple of rational and relational points that I think are interesting, and I imagine Naomi and William will touch on. So if we look at resource and capacity issues, if you move to the column on the right, adequate resources and staffing before implementing changes, phase rollout based on capability and capacity. Community care is not ready to take what is being suggested it will need to take. And we learned this from the Darcy experiment with community health centres before. We can ignore that reality as long as we want, but we do need to find a way of, if not dual running, certainly pump priming the environments in which we are shifting work, people, and care into. We have to create spaces where people feel ready and able to take receipt of that shift. And if we don't attend to that, this won't work. Then if we go to leadership and trust issues, if we move to the right, investing more in implementation, adoption, support, not just the product. Health Foundation published an interesting report about changes to the electronic patient record that suggested that only 17% of the budget set aside to support the implementation of the electronic patient record was spent on support. So training, culture shift, mentoring, modeling new ways of working. That is not going to work. We know that good change works when there is sustained support for the relational aspect of change and the implementation of the idea, not just the idea in itself. Third, culture and behaviour issues. This question about genuine psychological safety, I think, is really important. I'm hearing certainly for the first time in a long time, NHS staff talking about being fatigued, but also about being afraid. And that is not a good place for us to start. A position of anxiety is not a good place for us to start building change. We know that from Edmondson's work. High accountability, which exists, low psychological safety drives anxiety, and anxiety is not the best place to drive sustained change. It will work for a little while. So the Prime Minister talking about the NHS must reform or die. It creates some attention, it creates a little bit of momentum, but it's not going to be a sustained strategy. So we've got to find a way to inject hope. We draw on what we know from Edgar Schein's work. Hope is the way that we will sustain this. There's got to be some kind of reset and resetting of trust, particularly in the back of some pretty strong central intervention into the system. And then finally, the system and integration issues. This idea of aligning priorities across the system and the people in it. A bad system will beat good people every time. We do have to think systemically about what this means. There have got to be aligned incentives to shift in the way things happening. So that's what we heard. So that seems pretty straightforward. People are telling us what gets in the way and what's going to work. So what's missing? What are we not getting right? Okay, I've just popped to the last slide. So before I hand to Naomi and William, basically a little journey. On the top left of that is a techno-rational model of change. It suggests that A to B is a straight line. And for some of these changes, that will be true. But for most of this change, when we step out of Wellington House or our own places of work, what we're going to encounter is a much messy reality, and we have to attend to that. And we know that's true because if you work your way across the bottom, we've been thinking about this stuff for a very long time. Now, Naomi, I don't know if you recognise that report called Managing Change in the NHS.
It's leaving us on a cliffhanger. I think Shane's connection is dropped out there. Shane, are you still with us?
I can hear you, Claire. Did I
Oh,
lose
you're
you
good.
at
Maybe turn your video off, Shane, because you're frozen. But carry on.
Okay, I hope I'm not picking my nose. So just running across, I was asking Naomi if she recognized the report that's in the middle. I know you can speak to that in a second because that report came out in 2001, which Naomi sponsored. 2001, I was struck not only by the 24 years that we maybe haven't been learning from that excellent report, but also the cover was very interesting. It reminded me of something else, and then I realized it's the same similar DNA strand to the 10-year plan. So we know that this stuff has been working. We've got 7 principles that we know work for change. So it seems we're in a good place. Staff are telling us what they need. We know what works, and yet. So I'm going to segue now to Naomi and William to tell us how we bridge that sort of knowledge do gap.
Thanks, Shane. Before we do that, we're just going to ask people to rank on Menti of these 4 change challenges identified by staff. So, as Shane said, resource and capacity issues, leadership and trust, cultural and behavioural, and system and integration issues. Asking people to rank how significant each of those change challenges identified by staff feels to you. So, with 1 being the most significant. If you're anything like me, I was a bit confounded by how Menti does this. So everyone's much better than me at Menti. So just click on one of the challenges, and you can use the arrows to move up and down. So you can rank things from 1 to 4. We know that they are all important, but just how significant does it feel to you? So culture and behaviour coming out pretty strongly as number 1 there. But moving around a little bit, I will just let us pause here for people to let us know their perspective and rank. As I said, if you click on one of the change challenges, it will start to rank, and then you can use the up and down arrows to put it in the order of that you think is most important to you. I can see we've had half of people voting. So culture and behaviours. I don't know, Shane, any reflections on how people are voting?
No, I think what we're going to hear, I think from William and Naomi, I expect. Sorry, I keep telling you what you might say. I have no idea. But given your collective wisdom, what we're seeing here is we're seeing a relational set of needs, resources and capacity, system and integration. A rational set of needs, resources, capacity, system and integration, and a relational set of needs. And those are in an order that we instinctively know to be true, and yet, let's be honest, are often overlooked or not attended to in the way they might. So again, what we think we're stepping into is that how do we bring ourselves and others to do and know what is right and true?
Thank you. Right, I'm going to move us on and hand over. But thank you for those of you who've shared your rankings in terms of where you think these are. Naomi, over to you. What do we really know about making change?
Thanks, Claire, and good afternoon, everyone. It's great to be with you. Next slide, please, Claire. What I'm going to draw on is a programme of work that actually goes back to the 1990s, but don't worry, I'm not going to actually go through all of that because I was involved with a number of studies on hospital at home in the 1990s. Some people on the call might remember hospital at home. So the research programme on major system change and sustainability and some recent current examples, and there's a little key here about how they relate to the NHS 10-year plan and the shifts. So green is hospital to community, yellow is analog to digital, and then there's large scale change. So during the pandemic, we studied remote home monitoring for COVID-19 patients, also known as virtual wards, national rollout. We're studying community diagnostic hubs. We're currently studying the implementation of AI for chest diagnostics across the country. And we've previously looked at large-scale change in relation to acute stroke services across London and Greater Manchester, and also specialist cancer surgery in those same regions. We also have a research program on the role of boards in quality improvement. And of course, there's a lot of other very important research and evidence synthesis on implementing sustaining change in healthcare, which I'm also going to draw on. So the next slide, please. So there are a lot of myths about making change. Next slide, please. For example, that structural change is required, such as mergers and abolition of national bodies and so on. Secondly, that change is a purely technical endeavour, that we don't need to pay attention to social influences. So some examples of these: that innovations are standardizable, self-contained packages that can be mechanically transferred across settings. So we saw that with COVID virtual wards, whereby there was a national SOP, standard operating procedure, which was developed, and guess what, wasn't implemented everywhere because people adapted to their own circumstance and context, quite rightly. That digital AI are the magic bullets, and perhaps I'll come back to that because there's quite a bit to be said, particularly from our recent AI study. That top-down, what's called designated leadership, is sufficient. So we're still on myths here, just to be really clear. That policy and financial levers, so things like targets, financial incentives, will make change happen on their own. That we don't need to learn from history or context, and that additional funding and resources are not required. So those are the myths. Next slide, please. So with that, now coming on to some evidence. Next slide, please. So what we know from all the evidence is that it's important to build the drivers, the narrative for change, with a wide range of stakeholders from the beginning. So what's the evidence around which that you're making the change? So for example, in acute stroke, there was 20 years of really good clinical evidence that told us what we needed to do to provide high quality acute stroke care. So treat it as an emergency, thrombolyze within 4 hours, all these things, which are now completely we know them, but they're back in the day, not everywhere was doing those things. Then what's the theory of change? Who will benefit and how? So be clear about the purpose. To what problem is this solution? There is a tendency to start with the solution, whether it's AI or virtual wards or neighbourhood health centres. What problem, challenges are we trying to address? And then what might the solutions be? What do we know from the evidence, and so on? I know it sounds very, very obvious, and probably everybody on this call knows this. However, experience tells us that that isn't often what happens. Sometimes it's what happens, but often not. And there's particularly a tendency to grab at shiny, flashy tools. So as Shane and you all on the call obviously know from how you've ranked the challenges, that change is a human endeavour. It's really important to understand the social influences in developing the drivers for change and in the implementation. And there's a need to adapt to different contexts and over time, both the innovation and the change, so adapt and the way it's implemented. Next slide, please. So some helpful things to think about, hopefully. So we've found that the role of what we call agile network governance can be really helpful. So networks of providers, for example, in implementing over a large scale, or within an ICB, for example, can be really helpful. So a network of providers, whether it's called a collaboration or whatever it's called, it doesn't matter, but that holds everyone in that network to account for implementing the change, set standards, implement the change. We found that a combination of top-down and bottom-up leadership can be helpful. So someone or some people to hold the ring to ensure this change happens, but the change led from bottom up, preferably clinical leaders with credibility. we'll always get resistance to change. That's human, and often requires a system-wide authority to address that change, address the resistance. But well-distributed leadership can also help resistance deal with it. So, clinical leaders and there was one very good example from acute stroke in London, where one of the clinical leaders gave up his service, agreed for his service to be closed in order that acute services were centralised and provided high quality care. Appreciate that's quite unusual. Engage with all stakeholders, especially patients and the public, from the beginning. Co-creation, co-production, it does require robust governance, and learn from history, particularly where there's been issues with non-implementation. And the example, and I should say some of the things we study, some are successfully implemented, some not, or less so, and it's important to learn from those as well as the successful ones. And so we've looked at that in particular. So more things to think about from the evidence. So performance management is important with a whole lot of caveats, which I won't go into now, but I think probably you're familiar with. Financial support and levers are important, not on their own. And sorry, I'm going to mention double running of hospital and community. And I know it's the thing Mr. Streeting doesn't want us to talk about, but actually it's very hard to think about how to make that shift, or we need to think of other ways then if we're not going to double run. Support needed for implementation, headspace for the implementers. It does require funding. For digital, my plea is please don't ditch analog methods for patient-facing services. Again, I'm sure I don't need to say it on this call, but I have needed to say to people, remind them, because there is a move both nationally, but also in some local areas, to run ahead with digital. And there are many reasons why people can't or not able to engage. They may have smartphones but not feel comfortable using them for health reasons. They may have sight issues. There are a whole range of issues that people might not be able to. So please, that's my plea. AI, proceed with caution. Again, it's seen as, by some, as the answer to everything. And from our current study of it being implemented for lung disease, is that it takes the procurement is very tricky, has many challenges, which I can talk about later if anyone's interested. But the implementation, we're talking about legacy systems, so it has to be plugged in there. There's training issues, there's ethical issues, there's governance issues. This isn't to say don't do it. It's just to say just to be aware of all these issues that need to be dealt with. Evaluation, really important. I guess I would say that, but I actually do think it is in formative ways as you go, but also in summative ways, and to think about sustainability. So all of the above I've said is important, plus more adaptation to context, use of independent evidence of what you've already done, does it work, how and why, and consistent leadership. Next slide, please. So some final thoughts, top priorities from me. Start with the problem you want to address, not the innovation. Engage staff and patients and patient groups from the very outset. And there's a little quote from Papuzzi et al. About giving attention to human relationships, so that people can work together to embed improvements with reciprocity and goodwill, and productively harness conflict. It will arise, so how can we give a place for contesting views and bring them together in a constructive way? Retain analog option for patient-facing services, I'm going to keep saying that, and build an evaluation from the beginning. Thanks very much. This final slide, there's some further reading there, and I would draw your attention to the Papuzzi et al. And also our own work. It's Cambridge University Press have published a whole range of items on improving quality and safety. Ours is on the role of governance and leadership. The Papuzzi one is on approaches to spread, scale up and sustainability. There's a whole number, and I hope they're accessible and hopefully helpful. Thank you.
Thanks, Naomi. Such rich learning there, and we will share these slides afterwards so people can access that further reading. I'm going to hand over to William now, but we're going to come after that to pop into Menti, the one burning question or reflection you might have, and then have a discussion. So we'll be doing that after William. So note down any thoughts you've had so far or questions, or as William speaks about what he's learned from experience of delivering large-scale change. William, over to you.
So I could just make this a very short webinar going everything Naomi just said, and that would probably be enough. But I'm not going to do that because, you know, got to get the money's worth. So a couple of bits and pieces then for me. So I'm just going to not go through everything on this slide. Two things I do want to draw out on here, though. Firstly is I think there's something really important to think about when we were doing lots of engagement in the lead up to the 10-year plan. We kept getting told about stuff that was outside of the NHS, wait for the 10-year plan, wait for the 10-year plan. And actually what we got was an NHS plan. And we should be really honest about that. But what's interesting is it doesn't have to be an NHS plan. So there is huge opportunity in what has been put down on paper there to go wider than the NHS. And for anybody who's on here, if you are working in the NHS or wider, please find a way to bridge that gap, because the only way that we'll be successful in delivering its aims is if we can move this outside of just the focus of the NHS. And then secondly, there's much you can get on with now that works. And I think one of the challenges has been, particularly in the system, is everybody's waited, you know, nearly a year for this, and there's been an awful lot of stagnation in the system when people could get on with stuff. So there's people who've been doing brilliant stuff for the last year, but because people were waiting, it means that we've kind of lost a large part of a year outside of just the operational work. And I think you can just get on and do stuff tomorrow. You don't need to wait to be designated a site or go through a bidding process. And having done a few of those, trust me, you maybe don't want to be. So if we go on to the next slide, I'm going to talk briefly about what I've learned from large-scale change programs. So firstly, I want to be really clear not to fall into the myth that we haven't done a lot of this before. And there's two aspects to that. The first aspect is that this is a document which is effectively kind of, for anybody who was born in the mid-90s, this is now what I call music for health policy. It is a weird smorgasbord of things that we have looked at and done probably since the 1970s through till about now. That doesn't make that a bad thing. It just means that there is great evidence for nearly everything that is in that plan somewhere, even up to the most recent technological stuff, going all the way back to the change stuff. And I think that's really important. But the other one, and I think this is really important to call out, is lots of academics, lots of think tanks, lots of politicians, lots of other people have said, we've tried to do these shifts before and been unsuccessful. That is fundamentally not true. The shift from hospital to community has been deeply successful in certain things. And I think it's worth saying that if I look back to when I was clinically working first on the wards, I was working on a care of the elderly ward. Care of the elderly is now entirely in social care. So the things we used to do in hospitals is now done in care homes. That was a huge shift. Learning disability, similarly, over the last 20 years, we've shifted that from institutions into the community. There are thousands of examples of great things we've done to shift from hospital to community. What's interesting with all of them is they are specific. So how do you think about what is the population you're seeking? If your view is you're going to shift everything out of hospitals into the community, that's never going to happen, because some stuff needs to happen in hospitals and some people will always be best served by a hospital. But actually thinking about, are there populations who would massively benefit from having their care delivered in the community close to home? Let's start there. Let's think about who they are. And it's not just everybody over X or everybody in this postcode. It has to be more specific than that. Secondly, place really matters. So when you look at these things, you have to talk about what we mean by place. What's really fascinating in the neighbourhood teams work is to think through, there is going to have to be a demonstrably different model in coastal areas, from rural areas, from urban areas. Those three places, from the very nature of how they are constructed, how their workflows work, how their infrastructure works, how the transportation system works, even down to the way in which people move around those areas, is going to require an entirely different delivery model. That's That's not to say that the idea of a neighbourhood-based team which brings together teams of people to support people in place isn't the right idea. Absolutely, that is. The what of doing that is right, but then how you do that and how you implement that locally has to be variable. And when we did the work with the care homes vanguards, people particularly looked at this idea of there were some things that you could do consistently across those models, but actually how you implemented them had to be variable locally. So if you wanted to look at something like end of life care, which was absolutely critical for people living in care homes, that was the thing you had to do. You had to have an approach which built on gold standard framework standards, but actually whether that was delivered by a nurse, a doctor, a hospice, etc., that could be variable depending on what was in your local area and how relationships worked. Secondly, I think it's really important to start with the stuff that works, not the stuff that we don't know works. And I think this is to Naomi's point on beware AI and be cautious with it. There are just some things that work. So in the plan, it's very clear that we're going to bring in genomic testing into health checks alongside the health check, which in and of itself may well be the right thing to do in time, but actually we currently see huge variability in local areas between 20% and 80% uptake in health checks. So there's just something about if we could get everybody from 20% uptake of the basic health check, which we know works, which we know is one of the most successful hospital community shifts through interventional cardiology, for example, we could actually save many lives, save thousands of strokes, keep people out of hospital, give them a healthier, happier life. But actually, why would we want to put the genomics in from day one? Let's get the health checks up to a much higher coverage within your local area and then put in the genomics, right? And so it's about getting the right thing of doing what knows works. And again, that thing of the what is consistent, you need to do health checks, but how you implement that, that's going to be variable. And if you look at health checks as a program, well over 10 million people have had a health check in the UK. Interestingly, it's fairly abnormal in screening programs in not adhering to the slope of inequality, by which I mean people who have a health check, it isn't impacted by the fact that they're poorer or wealthier, and that's really unusual in screening programs, and that's largely attributable to the fact that people have locally implemented it in ways that are applicable to the communities that they're serving, largely away from centralized control as well, I should say, which touches again on this piece of you get the clear message from the top, but then get on with it at a local level. I truly believe this, having done this, it is about relationships, trust and common purpose, which again chimes with some of the stuff we said before. Change happens at the speed of trust. If you don't work with people, if you don't build those relationships, you're simply not going to be able to bully them into doing it. And if you have a operating model that forces people to do something, they're simply going to do it badly and they're not going to do it properly, which means you won't get the outcomes you thought you were going to get. Workforce really matters. We don't have a workforce plan for this. I'm pleased that there's going to be a workforce plan refresh later in the year, and that's going to be more realistic and less just about the NHS and its staff. However, people do stuff, not policies. I've written some brilliant policies that did nothing. Most of the work you do with real people changes stuff, and I think that's a really important message to take. And then finally, on delivering large-scale change, please embrace the imperfect, because if we try to do all of this perfectly, we are going to see huge challenges because you just simply can't do it. It doesn't work. And so there's a piece for me about how do you embrace the imperfect and get something that is good enough to deliver 90% of the intention and 90% of the outcome. So I'm very briefly going to touch on prevention. Prevention is very simple. It's about stopping stuff, right? It's stopping stuff happening. It's stopping stuff progressing, stopping stuff worsening, and stopping stuff harming others. So if you are talking about a shift from treatment to prevention, it has to be doing one of those four things. If it's not doing one of those four things, it's not prevention. It's been rebadged as prevention just so that you can get your product into that particular bucket. Okay. The three things you need to do if you're going to make this successful in the 10-year plan. Firstly, base the services we provide within those communities that need them. Start with the community to talk to them about what they need. Go population level where you can. So things like the smoking ban and smoking and vapes legislation and bill is a really good example of that. But actually, you need to target where necessary. And often we need to focus on the people who experience the greatest inequalities. There's lots of talk about genomics. There's lots of talk about targeted screening. There's lots of talk about using AI analytics to find the sickest people. They're the poorest people, guys. If you start just looking at your 20% lowest income wards, that will help you straight off. You don't need to use clever computers to know that the people poorest are the least likely to have care. And then finally, it's about creating the conditions for people to be healthy. And that means better legislation and regulation. And that's something that really only can be done at a government or regional level. Better access to care and joining up wider than the NHS. There's a whole group of people out there who desperately want to help and desperately could offer something. Go out there, embrace them and use them. And then finally, there's something about how does the cross-government do it. And then at the end of this, you have to have levers that will help this shift to happen. So firstly, money. You do need the money to follow. One of the big tests is going to be, in 10 years, are we still spending as little as we do now in the community and primary care as we are at the moment, or is that going to increase? Secondly, what do we do about people? And then finally, no one size fits all. So how do we take the principle of what we do as being common with the how being something that's locally variable? There you go. Quick brief spin through all of that.
Fabulous. Thank you so much. Some really common themes coming out through what we've heard so far. As ever, we are running out of time. We could spend all afternoon on this. If you want to spend all afternoon on this on the 11th of September, then Ariadne will pop the link in the chat. You do join us in London to do that on the 11th of September, because there's so much to unpack and get into here. I'm going to come to participants to share any reflections or questions in a moment. I'm not going to focus on this. If you want to get a copy of our little guide, do get in touch. We are reiterating some of the points that have already been made here about actually where to start. We think there are 5 areas you could start. As William's just said, plans don't make change happen, people do. So start with your people, not just staff, but also your patients and your communities. Pick an area, get staff involved, give them real influence, and develop some quick wins. There's more detail in our little guide, so I won't go through that now. I'm keen to hear from you. So do pop into the Menti now. Based on what you've heard, what's one burning question or reflection you have, and we'll put those questions or reflections to the panel. So I'll give you a moment. Thank you for William and Naomi and Shane, who've been popping links in chat for more information. As I said, we could definitely spend the rest of the afternoon on this. So one reflection coming through, the importance of not ditching analog, Naomi, your point, could exacerbate health inequalities for those living in deprived areas, those facing digital exclusion. Absolutely. Question for William. You mentioned care for the elderly has shifted to the neighbourhood social care in a really bad position. Would you count this as successful? How can we make disruption feel hopeful? I'll let people pop some more thoughts in. William, what about the question directly for you?
Never said it was successful. Did say they'd managed to do the shift from hospital to community, and I think that's the important thing is that it's possible to do these shifts. The issue then is what you choose to do with that. And so in and of itself, to think Shane made this point earlier and Naomi made this point, just because it's a solution doesn't mean it's necessarily going to do the things you thought it was going to do. And I'm not suggesting for one moment that the shift from hospital to community of older people's care has been entirely successful. But actually, if you look at the people in care homes in the UK, they have less than 1 hospital admission per year, which when you compare that to people with comparable levels of disease living in the community have 3.5 times, that's a fairly significant level of hospital avoidance, if that's what you're after as a principle. Similarly, they actually provide incredibly good care at an incredibly low unit price. And again, there are some real issues in that. And, you know, I can spend all day on social care, continuing healthcare and the real challenges of our care system. But the idea that we've never been able to shift things from one place to another, which is a common think tank trope, isn't true. And I think that's the point for me is there's hope you can do this. Whether you get it right or not is how you do it, not whether you do it.
Yeah, absolutely. Thank you. More reflections coming in. Thank you. We'll take these away and come back and look at what people are saying. One question around what does good patient public staff engagement look like in the delivery phase? I'll come to Naomi and Shane in a moment. I mean, certainly from our perspective, that point around giving staff real influence, so involving your team. So we've got a plan, but as William had said, from my perspective, I think one size doesn't fit all. What does that look like for you in your community? So how are we working with patients and with staff to really give them influence, give them that skin in the game about actually how are we going to take this national work for our team? So working with staff-led improvement groups, patient-led improvement groups to really drive that change locally and see what it looks like, and actually working with staff to understand, you know, what's their previous experience of change and what do people need for it to be different this time is certainly something I would come to. Naomi, I'll let you have the floor for reflecting on any of these comments that are coming through.
On the on the patient public staff engagement, I take it pre-delivery and actually involve all those people in prioritising the changes you want to make. So what are the key issues those groups want to focus on, given can't do everything? So this is starting with the problem. So prioritise the problems and then co-create the solutions that are relevant to your context and your place, as William said. And just to underline what William said about equity and inequity, a really important thing to think about is any potential unintended consequences of changes you're going to make. What impacts might they have on groups that find it difficult to access services, for example? Yeah, thanks.
Absolutely. And a lot of the work that we've done is about actually exactly that, Naomi. What's the stone in people's shoe, and actually how can we come together across different groups of staff? Because I think one of the things that we found, I think staff, when we did engagement, we did a lot of mixed engagement with different staff groups, and people were finding it quite fruitful that actually we've got a real common challenge here that we can come around to actually co-create a solution for. So I think it's bringing different groups together to actually find that common solution and prioritize and focus on one of those things.
And patients and the public are really important in that, because they have different perspectives from staff. And sometimes we're in our groupthink mode of what we think is important, and patients and the public come up with their own priorities of things they want to see addressed, which might be uncomfortable for us. But we need to have those discussions for change to really work. We want patients and the public to engage with the changes and the new service pathway, whatever it is.
Absolutely. Shane, I'm going to come to you again. The floor is yours for question. One of the things I thought was interesting in terms of a question was, how can we make disruption feel hopeful? But feel free to comment on that or some of these other reflections that we've got.
Well, just on that one, happy to respond. I think what William said is something I think is really important. There is a danger that we just all turn our attention to this plan, and then now we wait for delivery, and then we wait for permission to make things hopeful in how we turn up in our own work day to day. So there is a danger that we give away all of our power and agency, and that we may do that unconsciously because it sort of unburdens us a little bit. But I think there is an invitation here to look at what is working, to ask your people what matters to you, because in the same way as Naomi says, what matters to the public will be different. What will matter to colleagues working in services will be very different to the conversation we're having now. So tomorrow I'm going to be in a room with 40 senior nurses at South West London and St George's. I imagine what will be on their mind will be corporate manslaughter. What does moving hospital to community mean in the context of Nottingham? It will be, how are we going to recruit 85,000 new mental health care professionals in a way that doesn't repeat the mistakes that we've made in terms of ramping up our nursing workforce? So again, there's something about being situational, being contextual, being deliberate, doing some sense making, but also taking responsibility and accountability for us doing the next best thing. I think there is a danger that we sort of we just give all the power and agency away, and that's not, I think, would be complicit in that if we do. So I think the question is, what would you do? What can each of us do every day to turn up and be hopeful?
Absolutely. William, I'll just come back to you because again we've had more more thoughts and reflections. As I said, I welcome you focusing on any of these that you particularly piques your interest. I'm interested in the one around particular regions or systems that you may be aware of that are particularly well placed to implement, and what have they done. But it may be that you want to focus on a different comment or reflection.
No, I could do. I mean, so for me, I think we have to stop talking about things as being binary. Who's well placed, who's badly placed. There'll be some places that are brilliant, some places that are rubbish, right? But then there'll be brilliant at other things and rubbish at other things. Similarly, no policy has been truly successful and none has been truly unsuccessful. People forget that accountable care collaboratives were one of the 5 care models in new care models. Now everywhere is pretty much in a group model. That's a stealth change that happened as a result of the vanguards that nobody ever talks about, and everyone says vanguards failed. They didn't fail. They did some things really well and some things really badly, right? And I think it's really important for people to realize that none of this is binary stuff. What I do think is really important is understanding the context of your local area. I live in a coastal town. Coastal towns are fundamentally different to how you deal with this in a city, and so Tower Hamlets has an amazing primary care network system that has been in place for a number of years, does really good stuff. It's not going to work in a coastal town, but there might be something amazing that's happening up in Garstang or somewhere like that that is really relevant to a coastal town. And so I think it's that piece of understanding where there are features and functions you can take from elsewhere that you can steal with pride that will augment what you're already doing. The other thing to say is there's nothing new in this plan, with probably the exception of some of the life sciences stuff. And therefore, we've all been doing this for the last probably 20 years. So I can guarantee in every part of this country there is some work being done on some neighbourhood teams. It might be called primary care networks, it might be called clusters, it might be called groups. There's all sorts of different ways in which that's described, but the idea that suddenly we've got to develop neighbourhood teams that don't exist anywhere else, I mean, that's what MCPs were. I hate to break it to you. Before that, that's what half the pioneers were doing, and before that, that's half of what they're doing. And as somebody has put very rightly in there, that's what community hospitals were. They were Darcy centres. Yeah. Before we closed them and sold off the buildings and then built Darcy centres. There's still a lovely Darcy centre in Redbridge if anyone wants to go and see it. 6,000 square foot of building. I don't know whether it's now full of people doing really interesting stuff or not, but it's not like there aren't features of the future somewhere in our present.
Yeah, absolutely. Having spent the last 26 years trying to implement different names of things that look scarily similar to this, so absolutely so much learning out there. We've got 4 minutes left, so I'm gonna come to share to ask colleagues to give a closing reflection. Interesting point here around, with a much reduced workforce in ICBs, how will this transformation be made a reality? And I'm interested also in how well understood do we think the myths and truths are, and how can they be influenced, and how. But I'm going to come to our speakers for a kind of closing reflections. What I'm just popping up, final Menti question for participants. What's the most useful insight or observation you've heard today that you'll be passing on to other colleagues? Let us know. Hopefully you have found useful insight or observation. I'm going to come to Naomi, Shane, and then William for just a closing reflection. Reflecting on, I think there's some really common themes that have come out in what's been discussed today. What would be your first next step? Where would you start if in implementing this plan? Reflecting on all of the advice and that you've shared so far, what would be your first next step? So just really briefly, Naomi, Shane, and then William.
So I want to address Jill Rogers's point in the chat or question about, with the workforce feeling like they do, scared, exhausted, etc., how do we truly and authentically include them in the shifts? And you can read the rest of it there. And I think, it's turning that round. We all get up in the morning to improve things. And that's what's motivating and exciting and interesting. So that, if you look in any healthcare system, people are on the ground doing quality improvement projects. They're trying to improve their bit of the service, and it's very inspirational when you look at that. So I think it's about turning it round and saying, acknowledging people are scared, exhausted, and so on, and saying, you know, let's come together, let's improve what we're doing, let's improve the quality of care and how you come to work every day. And similarly with patients and the public, there's a lot of, you know, energy there from people who want to engage, who want to contribute.
Fab, thank you, and thanks for people sharing their thoughts and reflections. Shane, 30 seconds from you, and then on to William.
Yeah, next best thing. So what I would love to see if I was able to influence the centre would be a sort of an implementation. I think a plan is really misleading. This is too complex. There are too many things that need to be parsed out. But I would love to see a study that says, we've listened to what staff say you need. This is what we learned from change in the past, and this is what we're actually going to do about it. Just as simple as that. Just an expression that we have learned, and we're going to do something with that learning. And then I think locally, I'm really hopeful. I think though, the 3 questions that Doug Conant always asks remain, which is, do you understand what it is that we're trying to do? Do you have what you need to do it? And how can I help? And I think that's a question that's available to those 3 questions are available to all of us. So let them and let us. Lots to play for.
Fab, thank you. William, final word on to you. I'm going to pop up our evaluation form.
Get on with doing good stuff. That's why you all came into this job. Go and do good stuff. There's brilliant stuff going on already. Just do more of it.
Fabulous. Yeah, so crack on. And if anybody would like to have a follow-up conversation, then please do get in touch. We are passionate and keen to make this work and help you all achieve those aims. So we've just popped a quick evaluation form. Anything else you'd like to share, let us know how this event was for you today. If you want to come along on the 11th of September in the afternoon in London, we're going to get much more into the detail for a whole afternoon face to face. Do join us. Or if you'd like a copy of our little guide to implementation of the 10-year health plan, then get in touch with Ariadne and she will send you one in the post, an actual real life letter in the post. So thank you so much. It's 2 o'clock. I'm roasting. I'm going to go and throw myself in a bucket of cold water. So thank you so much for joining, and look forward to seeing you all somewhere very soon.